So my base job is the Director of Nursing at Wanganui, plus I look after the patient safety area as well there. And have been seconded in the last 12 months, 2 days a week, to work with the Health Quality and Safety Commission as the clinical lead for falls injury prevention, which has been really good because it's a good thing to have your foot in two camps. You can influence policy, but you also know really what works and what doesn't work. So that really helps. I mean, the Commission has sponsored Frances to be here with us today, and it's a great honour to have Frances Healy with us. If you've done any research at all on falls, you will come across her name countless times. So, and the fact that she has a nursing background is exciting because she is a nurse. She still has a current practicing certificate. So that really impresses me. And to work in the area of academia and research but still be grounded in reality is a fairly rare combination to have. So today it's your day, and Frances will run through a number of things to run through, but if there's any questions from the floor, I know she will appreciate, and she also wants to take something back with her. In Canterbury have got a particularly good model of community support for people that fall, and there must be some good ideas going around in the hospitals as well. So talk about your experience so that Frances can also learn from you, and I can learn from you. And I don't do a visit where I don't learn something good about every place that I go to. So it's really powerful. It looks like I'm starting up, and Frances just said to me on the plane this morning, before the plane, what are the 10 challenges in hospitals fall prevention? I know there's a couple of aged care people here, but I think this morning's session was predominantly about hospital, and this afternoon's session's about aged care. So when I use the word patient, just please forgive me from aged care that I'm meaning resident or client, whatever term you're familiar with. And I guess the 10 greatest challenges was that when I started this work, I thought, well, what's going on in the world of falls injury prevention? So I sent out a survey to all of the DHBs, asking them, do you have a policy? Do you have a committee? Do you have, and there were a number of questions that we sent out. And it probably won't surprise you, well, with what came back was really like, I could describe it as spaghetti really in a tin. Everything different everywhere you went, even in one place they had, you know, bigger places sometimes had more than one policy depending on what area you were in. So it sort of told me that there was a scattergun approach and everybody was doing their own thing. Look, everybody was doing something, but it was just so vastly different. And then the next bit of work I did was pull in all the risk assessments from around the country and looked at the nursing risk assessments. Because I am a wee bit one-eyed sometimes, though I do understand falls is not all about nursing. But I just pulled in those risk assessment tools. Well, it's really interesting because you have the places that say this is the best evidence, and we've got the evidence tool, which was probably developed in 1994. But when I compared what I could see on those risk assessments from what the latest evidence, and I was talking 2013 evidence was telling, and a lot of that's influenced by Frances, they didn't meet the mark at all, and there was no two alike. Does that surprise you? No two alike. So we've got a nursing population that moves, and we've got different tools in different places. And the care planning, may I say, was even more abysmal. Nursing care planning. So I'm being tough because I'm judging myself as well. So it's not a criticism that it's better anywhere else. I think this is an international problem. It's not a New Zealand problem. But we're small enough to be challenged and get it right. So the first challenge is how do we standardise in a place that actually standardisation is a bit of a word that we don't like too much, because we're special and we might be big or we might be small, but we're special and nobody understands our population. But you know, the people that are falling here are the same people, the type of people, the same conditions and the same reasons that are falling in my little place of Wanganui. In fact, I'd almost say that probably the Wanganui people, a lot of people are old, look old at 50, look more like 70, and their health's more like 70 than 50. We have 26% Indigenous, as well as a lot of very poor people. Our average wage in Wanganui is 35,000. That's the average. So we're poor in Wanganui. So the challenges are, if we believe that by knowing what are the risks of an individual, and knowing that we have to address those risks to help keep that individual person safe, how do we do it well? And so when I've also, a lot of you, I've been to the West Coast, been to a lot of places, been to Burwood, had a look at a lot of different nursing assessment forms. Most of them are quite thick. When a new patient comes into hospital, there's a whole lot of assessments to fill out. So you start at one, maybe you do the falls one, and they ask you about mobility, and they ask you about skin, or they ask you about fragility. You go there and do a Waterloo maybe next, and what does it do? It asks you the same questions all over again, but you score them different. The first time you score it this way, and then the Waterloo you score it this way, and then you do a nutrition one, then you do this one, then you do that one. If you mapped how many times you ask the poor patient the same question, if indeed you ask them, and the nurses spend all of their time doing a big, thick assessment and struggle at times to have a care plan that's about that individual. Now, we're very good at care plans that got tick lists, and everybody gets homogenised ticks. Tick for this, tick for that, tick for that, tick for a call bell, tick for all sorts of things. So our challenge is, how do we get the care plan to reflect what that individual patient's risk is? The next challenge is, how do we get across everybody that there's a number of things that all patients need for patient safety. And it doesn't really matter whether you've got your full space of head in, or pressure ulcers, or any other reason. They come into a strange environment these days for a very short time. They flip over and go again. A large number of them are over 75 years of age. A large number of them suffer from dementia. So how do we look at that individual and that kind of environment and keep them safe? Now, my thoughts are that for all of those patients coming in, there are some set things that must be right. We must have the call bell and reach, and indeed if they can remember to use it. And I mean that in a kind way. They might have confusion, delirium, dementia, but have the bed at the right level for that particular patient. We need to keep our environments uncluttered, and we need to make the environment as safe as possible for the people in our place. And I was just recently looking at beds, and their toilet doors in their dementia ward are all painted blue, so that patients know exactly where to get to the door, because it's painted a different colour than all of the other doors. There's lots of good ideas around the place. There's Nelson Marlborough. I was really impressed by the ATNR ward, because when the patient comes in with a left side of weakness, they swing the bed around so the weak side's against the wall. How often do we have beds like the head there and the bed running that way? We don't think about whipping it round that way to keep that person. That's about individual care. For patients, a call bell can be individual care if they can't use their left hand and they have to always push it with the right hand, so you put it. The other thing about the ATNR ward at Nelson Marlborough is there's a couple of things that got me. The call bells, have you ever tried to use those complex call bells to get one's for the bed height, one's for the bell, one's for the light above the bed? Yeah, they're very complicated if you're really unwell, and particularly very elderly. They changed theirs to just a jelly-looking feeling one, which sits nicely in the hand, and it's got two big buttons on it. And it doesn't matter which button you push, either the light will go on or the call bell will go on. But, you know, in one place I went to, the night lights were up at the back, and the person had to stretch up. So I guess that's a lesson around what are those cares that we should give to all of our patients, no matter what their risk, no matter what their age. And then what are the individual cares that that person needs to keep them safe. Some of the other challenges are that nurses, the churn of a ward, they're coming in and out. Now, surgical patients now used to come into the ward before the day before surgery, and you'd have a chance to do all that reassessment. Now they come back straight from operating theatre, probably 100% of the time, really, 99.9% of the time. They never go near a ward. So you've got somebody post-operatively, it's a hard to do your risk assessments at that point if they haven't been done thoroughly before they come in. And also sometimes they go to pre-admission, 6 weeks out? And a lot can change in 6 weeks. So that's another challenge. Another challenge for falls, I think, and I might be getting close to the 10, is operating theatre in areas like that who think that they don't have falls. Children's ward don't have falls. You know, if my 3 boys are any reflection on falls for children, they have plenty. Some areas think it's not their problem. And the biggest challenge really is getting falls on the discussion of your multidisciplinary team meetings. And I think I witnessed a really good multidisciplinary team meeting in the neurosurgical ward here at Christchurch Hospital when I was here last. And it had every member of that multidisciplinary team around the board, and they were discussing all of the risks, and they did discuss the falls risk. The last challenge I'll talk about is it can't be just a nursing problem. Our healthcare team does have a wide spectrum, has doctors and allied health, but also has the cleaner, the person who gives out the meals, the visitors that come in regularly to see their loved ones. So how do we know that this person in this bed should not get up without assistance? What is it that tells anybody? And you don't want other people who are not trained to help them get up, but you want them to call for a staff member. So I've got some things with me here around the commission work, and I think I was probably meant to talk a bit more about that. But the Central region have been doing some work on signalling. How do you have a little a symbol that everybody recognises on the PD board, and then how does that translate to what goes above the bed, or so that visitors? So you'd hope in particularly in ATNR wards, it's very probably easy to get that because patients stay a bit longer, but their families get to recognise what these symbols mean as well. And I guess the last challenge as a director of nursing, and I put it out to you, is can you truly say that the family and patient are involved in their risk assessment and their care planning? Because we can put strategies in place and they won't work if that's not right for that person, and the families know so much and they have their own strategies that they deal with it at home, because most families try really hard to keep their loved ones in their homes. They don't really want them to go to aged care facility, and so they've learnt to do some remedying in their own homes. And so I guess my job as clinical lead is to share the good ideas around the place. But also I'm doing some work, and I have to thank Southern very much, because in Wanganui what I did was put the risk assessment into Trend Care, and we've got the carts and the computers that go to the bedside, and now I'm going to move in all of the risk assessments for nursing into one tool and one care plan. And Southern have taken up that idea, and I don't know that they've started using it yet, but they sent me the copy of it yesterday. And I'm really thrilled because, you know, the 1 or 2 or 3 things that are specific to that patient about falls, and it might only be 1, it might be 2, you actually handwrite. The rest, you know, the call bout in place and all that, it's all right to tick that out. And the only way you know that's accurate is you audit it in your monthly audits. But they've actually started that work, and I'm thrilled with it. So anybody from Southern here?
It was launched yesterday as part of April Fools.
Very impressed. I just need to give you feedback on that. So what I've got with me, I'll stop talking now because I'll talk forever and Francis will never get up here, is I've brought some copies of the topics. I asked you to go to the Health Quality and Safety website and look at these topics. Now, particularly, where's Val gone? Val might want to use them for her team. There's little quizzes on the back. Now this is evidence-based, it's actually done really, really well. All the latest evidence, and here you see Francis all through these. But on the back there's a test, and in Wanganui I'm going to start to put that into our PDRP. So I expect all my nurses in the month of April to finish this topic 1, which is about awareness of falls. There's some information about the signalling system here. And remember that we have got the quiz coming online again. I think it's in for testing today, the IT. It'll be out in a couple of days. And if you've try to get your staff in the area that you work to complete that quiz. It's the same quiz with a couple of extra questions than last time. So I've got some things here and I'll share with you as the day rolls on, but I'll just say goodbye now and let Francis have a go. Francis.
Thank you very much, and I'm really grateful to have been invited and to meet you all today. I'm going to talk about 10 challenges, but you could all write a different list of 10, and I know they're things that aren't a challenge anymore because you've done brilliant things and already fixed certain issues in your practice. So to some extent, the 10 things I'll talk about may feel slightly random because I started off trying to think, well, 10, that's a bit of a long list, but I could have gone on to 20, 30 or 40, I think, because there's always so much we can do in the field of falls. So, though I'm focusing on falls today, bone health is of course equally critical. So I'm just apologising that I won't actually go there today because I couldn't fit everything into the time available. I am very fond of my evidence base, and we sadly now have almost more systematic literature reviews in hospital falls prevention than we actually have randomised controlled trials, and they all come out with slightly different recommendations. I'm mainly going to draw from our new NICE guidance, CG 161, but it is, as I'll show you when we go through, remarkably similar to what you cover in the 10 topics here, because both are drawn from the evidence and hopefully also some practical insight, because I've been very grateful in the 32 years I've been a nurse now to have learnt from some wonderful frontline staff of all disciplines. To have learnt from research experts and clinical experts in the field of falls prevention. I have learned a lot in the saddest possible way through sitting through many coroner's inquests, which I suspect many of you in the room would also have done, to start with for my own patients, later either to learn for national advice or as expert witness for patients who've fallen in other people's care. But the only true good outcome we can get out of that is learning for future patients. And I have learnt a lot from patients, particularly patients who don't conform to the patient role and make sure they rightly teach their care staff how to fit in with their needs rather than us having them fit in with our processes. And in the UK, I've been privileged to be involved in developing the advice, the guidance we have, which tries to bring together the evidence base with practical insight as to how you can make that work in the real world, and this is mainly what I draw from today. Just want to check who's in the room. These are a couple of quotations from systematic reviews. First one emphasises that leaders and frontline staff really need to be involved. So do feel free to put your hands up twice, but can I just ask you to raise your hands if you're in a leadership role? And if you're in a frontline clinical role? Great mix. We've fulfilled the first criteria then of making falls prevention work. Who's from a nursing background? Medical background? Carl's precious to us. Pharmacy? Great. Therapy? And anything else? There. We have the perfect multidisciplinary mix, even if some professions are slightly more dominant than others. So briefly on the scale of the challenge, we have very similar challenges, I think. I've put up our population figures, relatively speaking, so that we can compare some of my statistics about falls in hospitals in England and roughly divide by 12. But we have very similar current age profiles of our population, and we have a very similar future age profile, which is the red side for New Zealand and the sort of fainter areas for UK, in that we will, because of wonderful increases in life expectancy, public health and healthcare, be grateful to have more older people in years to come. This is a pretty frightening figure for falls in hospital in England and Wales. Over 250,000, which is the kind of figure that it's almost hard to grasp. And we know at the peak time of day for falling, which is late morning for us, this actually represents a patient somewhere in a hospital falling every minute. So we have a massive challenge. Dividing that down to a New Zealand context, that would be something like 20,000, 25,000. But equally, you may well be better than us and have lower figures. We think there's about 2,000 fractures, at least reported fractures, after hospital patients fall in the UK. And they are predominantly fractured hips, because although in the community your Colles fractures will normally be greater in number than your hip fractures, it is that frailer, iller patient population who are probably not well enough anymore to put a hand out to save themselves. So where we do have fractures, it tends to be the most devastating sort. I've got a little clip here from a patient. I don't think the volume's going to be good enough, but I'll give it a very brief try. And would you just shake your head if it's inaudible at the back, and we'll skip it.
One occasion I went to the toilet, and I was escorted there and left inside for real privacy. I got up from the toilet, went to wash my hands, and I slipped. And there's an immediate shock of landing on your back. And then the terrible thing was I realised I couldn't move through lack of strength. I couldn't reach the pull cords, and my voice was also very weak at the time, and I couldn't really shout. And gradually it dawns on you that nobody's going to come and help you. And then I was actually on a cold tile floor, and I started to get cold, and that is when fear starts to strike you. You begin to think your body temperature is going down, and there's no way anybody's going to contact you. And that is a very, very fearful experience. You really don't want to have that. In the end, the nurse came to check on me because I hadn't reappeared in my bed, and I was found and I had to be hoisted up and all the rest of it, checked out with brain scans in case I'd done any damage and all that sort of thing. And it was quite some time that I really was beginning to get cold. It felt a long time, but looking at the clock afterwards, it really wasn't that many minutes. And that cold feeling and fear really comes into you and eats right in. Not pleasant. No. Because of the previous injuries, this was really a minor thing, but it was because I had no memory of the previous injuries. It was actually a major thing for me. And this is one of the things that I've carried from the accident, whereas the accident produced far more damage. But this is one of the things that hit me psychologically. And it's still there. Still there. That's over 2 years ago.
Sorry if that was a little faint to hear, but hopefully you got the gist. Now that's what we'd record as a no-harm fall, but had made a real impact on him, you know, still 2 years into his life. We know, unsurprisingly, the patients most vulnerable to falling are the very old, the oldest old. Obviously we have more bed days occupied by older people, just as you do, but actually our highest risk compared to bed occupied days is the over 85-year-olds. And of course the only reason this graph tails off is because we don't have very many 90 and 100-year-olds in hospital, but we even have that last little national statistic of people aged over 100 who've fallen in our care, which is sad. Question for you here. Obviously we have more older females because of differences in life expectancy, so we tend to have more older ladies vulnerable to falling in hospital. But all things being equal, if we had the same number of older men and older women, which gender do you think is more likely to fall? Hands up for men. Yeah, hands up for ladies. In any study that's actually controlled for bed occupancy, it is the men, which I kind of think is rather lovely. I think this is the same reason we used to have cheaper car insurance if we were ladies. That perhaps a certain attitude to risk persists into older age. But what we know we have are very, very multiple pathology people who fall in hospital. This is from an audit where we looked at people who had fallen in hospital. Nearly all had mobility problems, 2/3 cognitively impaired, 2/3 bone health problems, more than half continence problems, half on medication that's likely to increase falls risk. 40% with either cardiovascular disease or postural orthostatic hypertension, over 1/3 with significantly impaired vision, and over 1/3 with delirium. And as you will have worked out, those percentages don't add up. That is because most people had 4 or 5 of these conditions, and some had the full set. So we do have a challenge on our hands, and when people talk about falls, it normally starts with assessing risk of falls. I'm going to start with just asking, has anyone here fallen in the past year? I have. Yeah, it's perhaps slightly less than 1/3. There's this statistic, I don't know if it's quoted as often in New Zealand as in England, that 1/3 of older people fall once a year. Feels like me like 1/3 of younger people fall each year, so I rather suspect there's more than 1/3 of older people fall each year. They just maybe don't choose to tell us about it. So, incredibly important to do what your guidance suggests, which is always ask about falls in any healthcare contact, either with older people or people with the kind of health problems that will make them old and vulnerable before their time. Just want you to spend a couple of minutes talking to your neighbour and think of a couple of things that would worry you if you asked someone about a fall and then you asked them about, well, how did it happen? What do you think happened? Just brief discussion on what would be real alarm bells to you if you talked to someone about a fall and they talked about certain causes or consequences. Just when you were having a decent conversation, I've stopped you again. But would people be able to just shout out a few things that would really worry them if they heard it in those circumstances?
Can I just share something this weekend? I came across a woman who came in and was loss of consciousness and came in with a GCS of 8. At 28, it sort of, as she came around, I said, what happened? She said, oh, I was in the forest running and I fell. Unwitnessed, nobody knew. You sure you haven't had another fall in the last couple of weeks, last month? She was sort of drifting in and out, blood sugars were normal, blood pressure was normal, ECG was normal. I said, you sure you haven't hit your head? You sure you haven't had any previous falls? Oh, 16th of March, I fell down a bank. How big was the bank? 10 metres. What were you doing? I was running. How long did it take you to get home? 4 hours. Did anyone see you? No, it took me a long time. I had to try and find my way out. And then I said, are you sure you haven't anything else? I found myself on the floor 2 weeks before that, after my run. And I said, well, so you could have had 3 unwitnessed falls hit your head. You know, she wasn't having a subdural because her pulse was still okay, but there was these unexplained episodes where she's probably hit her head, whether that was an inner ear thing, whether it's a tumour or whatever. You know, I sent her for neuro and sent her in for being investigated. They're going to put a Holter monitor on, they're putting him through the MRI, but this is a 28-year-old who's
Yeah.
falling
Yeah.
with exercise, that could be a cardiac arrhythmia.
Wonderful story. So
But it
by
sounds
asking
like
about a falls history, you could have saved a life there.
Yeah. So it's just, you know, sort of asking a bit more questions instead of digging back, or just thinking, oh, well, all your recordings are normal, you can go home.
Yeah.
No, this doesn't add up. You shouldn't be
Yeah.
28 and tipping over and not remembering. And, you know, why did you actually fall? Did you actually fall over a twig? Or did you go down because it was an arrhythmia? It was unwitnessed. It's sort of like, it could be a number. It can be diabetes, you know, all sorts of things can happen while people fall. It can be a medical condition, it can be all sorts of...
Brilliant example, and I hope you get to hear about one day, you know,
Yeah, I quite often
how
follow
she's
them up and I
sorted.
sort of-
Other worrying signs people might want to quote from your discussion just now? What else would particularly worry you, albeit all falls worries?
The environment that they were in.
Right. So if they were describing a hazardous environment, yep, great one. Any more for any more?
You quite often get the elderly person who thinks that falls is a significant risk, but not for them as individuals. And some of that's around loss of independence and
Yep.
you know,
So if there was a big gap between their falling and their perception that they might do it again, that would worry you? Yeah, great one.
The other thing with public hospitals, and I mean, I'm coming left centre because I've worked in all sorts of areas. I can't understand, you know, I can understand we get a lot of falls, but we've got such slippery blooming lino. Why the hell don't we do something about it?
Challenge
Sorry,
number
I
9. So I'm going to hold you on the flooring and we'll get to challenge number 9. One of the interesting phrases that I curse when I hear is a lot of people will say, and patients sometimes will say, that they didn't need assessment because it was just a simple accident. So the bit I wanted to bring over there is that humans are natural storytellers. If we have a syncope, if we have a faint fall, we often have amnesia, but with amnesia for the amnesia, so we don't know we've lost a spell. And people will tend to explain that sort of faint by something in their environment. You know, if there's a cat in the house, the cat will be blamed. If there's a rug in the house, the rug will be blamed. Typical one is saying, it was my fault, I was rushing for the postman. Now, what actually do you do if postman or someone knocks at the door? You stand up. So that's a fairly typical sign of a postural hypertension, you know, and the patient will make up a story that makes sense to them and be quite convincing when they tell you. So always be aware there could be a loss of consciousness they're not aware of. Certain injuries will make you think that, but also just because it's a plausible story, don't forget it. And the word mechanical fall, does that sin exist in yours, by which people are trying to imply it was just a trip? You know, how do you know unless you've assessed them for all the other risk factors? So in terms of assessment, falls risk assessment is a phrase I try not to use because it's used to describe two completely different things. Something that I'll call falls risk prediction scores, something with numbers, and it's also used for a checklist of modifiable risk factors, so a sort of prompt list of what you may want to ask the patient about. The problem with the scores is they really don't seem to work very well, and I won't belabour the research to you, but effectively it's really, really easy to have a tool that's either sensitive or specific. By saying sensitive, I could make a very sensitive tool by saying only people who are over 90 with unsteady walk with a Zimmer frame are at risk of falls, and it would be remarkably good at identifying people who are at risk of falls. Or I could say everyone here today is at risk of falls, you know, and it wouldn't miss a single person who fell, but it wouldn't do you much good either. And this is the problem with most of our tools. I will show you more reading at the end. I will simply mention that Dr. David Oliver, who I often co-author with, the poor man invented Stratify and has spent the rest of his career trying to persuade people not to use it. It's very usual for researchers to go and criticise other people's research, but when a researcher criticises his own, you do have to listen to him. And this is how the tools work in perfect research conditions, how they work in normal clinical practice. Our biggest problem is that somehow it becomes symbolic of something having been done. You've done a risk assessment, sorted, which is a strange thing to fall into. So our guidance says do not use falls risk prediction tools, and our hospitals were fairly ready for that. We're already down to about 2/3 don't use them. We've got a third, a quarter we're still working on. And simply start from the point everyone in hospital is very ill, or they wouldn't be there in this day and age. Most of them are elderly, most of them have multiple illness. We know we have people who may be 50 or 60 but are much like a 70 or 80-year-old who's had a more privileged life. And that again is a very similar approach to your 10 topics guidance in New Zealand when you'd consider Maori and South Pacific Islanders as older people at a younger age. So we have to worry about the risk factors that can be treated, improved or managed. You know, we are the age we are, we can lie about it but we can't change it. Now, Miss A has been carried around the world with me. She was a real patient of mine, one of those who steers themselves into your memory. She's been a little bit embellished over the years, but she didn't need embellishing very much. What I'd like you to do, again, is just briefly have a conversation and see how many risk factors in that little pen portrait you can guess at. Obviously you're guessing because she's not there for you to ask questions of, and if she was, she wouldn't answer them anyway. And just see between you, quick fire, how many risk factors that we could possibly do something about can you find some hint of in this little pen portrait. Okay, I'm going to stop. You've had precisely 2 minutes there, which isn't very long. And I'm just going to check how many risk factors did you get to? Who got at least... Actually, everyone put your hands up and you'll take them down as I count. So if you got at least 4, put your hands up. I'm sure everyone did. At least 5, keep your hands up. 6, 7, 8, 9, 10. 3. I've probably collected, from days like this where I've had a chance to take more detailed feedback, I think I've collected about 40, 45 risk factors that people have come up with in discussion, all of which have some hint there and some of which I never realised might be there either. When you had your discussions, do you think you came up with more risk factors between the pair of you than you would have on your own? That's why falls prevention is a team business. You know, however much we know, that open inquiry and discussion usually leads us to suspect other things. So I'm not going to belabour the risk scores may not be a good idea point, but even if you continue to use one, you're going to have to rise above it and think of what actually needs assessing for the Miss A's of this world. And if you're developing policy or practice, I have known committees spend months, if not years, agonising over risk assessments. Just think backwards. You know, you will have certain interventions to offer. And strange though it is to start with intervention and move on to assessment, you know, if you've got interventions like safe footwear or walking aid in reach, it's pretty blindingly obvious who actually those need to go to. You know, the safe footwear needs to go to the people without anything safe on their feet. The medication review needs to go pretty much to people who are on medication. I don't know, do you think you have many patients who aren't polypharmacy, at least in a hospital setting? It's a rare patient on only 1 or 2 drugs. So it's just a different way of thinking about it, but turn your thinking upside down if your hospital or service is worried about what risk assessment they should use. Work out what interventions you've got to offer and then worry about the risk assessment another day. This is the list of what we suggest should be the core risk factors that can be modified that are assessed for in our UK guidance. It's remarkably similar, if not apart from wording identical, to those in your Ask, Assess, Act guidance, because both are drawn from the same evidence base and both are trying to keep it fairly focused and as simple as you can make falls. So nearly all of the challenges I'm going to cover come down to that individualised care planning and these risk factors that we may be able to do something about. So our guidance in terms of intervention simply says look at those risk factors, do something about them, and be realistic about what you can do during a hospital stay and what may need to be done once the patient's left your care. And that again is very similar to your Ask, Assess, Act guidance. I am absolutely passionate about individualising falls prevention. That is mainly because the first job I had where I really had to confront falls risk was a medical psychiatric unit. So we were innovative in our day, that it was a long time ago and other people have done it better since. But we had patients who either had an extreme delirium or dementia that couldn't be managed on a normal general hospital ward and were much too ill to be managed in a psychiatric unit. So we had dual qualified staff, people with end-stage cardiac failure and an agitated depression, people with leg amputation who could not recall they had had their leg amputated, which is perhaps the greatest falls nightmare in my memory. And for that patient group, they taught me very quickly, you know, all you could do was find what suited that particular individual because they were very much at the extremes of the challenge. So this is a phrase I'm rather fond of. And our NICE guidance said something similar. It says you don't offer one-size-fits-all falls prevention interventions. They've got to be tailored to the combination of risks the patient has. We've had a national audit that was very much glass half full. It didn't have surprises for me when we did this 3 years ago. There were a lot of things we're not doing well enough. But half of the patients who fell in hospital were on medication that could increase their risk of falls, but 23% of those didn't have their medication reviewed. And medication is my first challenge intentionally because I honestly think this is where one of the areas we can make the biggest difference. Sedatives, antidepressants increase the risk of falls substantially. And if you look at what distinguishes people who are injured in a fall for hospital, all the significant risk factors are related to medications of one sort or another. And we actually have some really good studies, perhaps the most successful hospital falls prevention studies, though they don't seem to get cited as often because they were primarily meant to better manage medication, and reducing falls was almost a pleasant incidental finding, was reducing prescriptions of any medication involved in falls risk. Just reducing dose and frequency of the sedative medications in the USA in the second one. And in my own Falls Safe project, by educating nurses as influencers, they reduced night sedation use in mental health units and in acute hospital units from what was an average of 1 in 3 patients down to 1 in 10. And all of those delivered significant reductions in falls rates. It was interesting how that worked in Falls Safe. Part of it was we knew when it comes to night sedation, generally speaking, nurses are a bad influence on doctors. You know, we tend to be the ones to say just prescribe it in case. So we stopped them being a bad influence and made them a good influence. Interestingly, what also changed was how they talked to patients. What they found was actually patients didn't care very much about the falls risk. They just wanted a good night's sleep. But what probably changed in how our Falls Safe leads talk to their patients was saying, actually, this won't give you a good night's sleep. You know, if Mrs. So-and-so's getting up to the loo next door, if we're admitting someone next to you, you know, that's not what sleeping tablets do. And instead being able to offer earplugs and eye shades and issues like that. But it seemed to be explaining that a sleeping tablet will not magically give you a great night's sleep in hospital, did more good. For those who want to learn more about medication, there's a really good resource with traffic lights of all the culprit medications written by a colleague in Falls Safe. And it does have green lights because, of course, medication isn't all evil, giving people pain relief so they can move comfortably, giving them a Parkinson's medication on time, and giving them their vitamin D, which probably has an effect on reducing falls risk as well as improving bone health, is the good side of medication. And the only little possibly new idea I can give you is that medication has to be paid for. So you nearly always have pharmacy accounts that will tell you quite easily what the pattern and trends are in medication use, including sedatives. And medicine reconciliation is a great thing, but what older people need when they're ill is more review than reconciliation, in terms of they are not themselves at present. What their GP thinks they were taking at home may not be actually what they were taking at home. And hospital is actually a safe place to test discontinuation of some medications when you can do so. Before I move on, I just want to say that though night sedation, benzodiazepines are a risk for falls, abrupt withdrawal of benzodiazepines in someone who is habituated creates the most cruel and distressing delirium that you will never forget once seen. So for someone who is habituated to them, this very, very gradual withdrawal is extremely important. Cognitive impairment. Obviously dementia affects falls risk not only through the obvious of not recognising hazards or their own limitations, but it's a neurological disease. There's changes in walking patterns, particularly prone to postural drops in blood pressure, delayed reflexes to save themselves. They're often given sedative medication and they have a high risk of developing delirium. It's even more of a risk if no one realises the patient is cognitively impaired. So we're just going to have a little competition here. We can all vote for our own professions if we wish. But if you had to pick one of these three who is the best at spotting confusion in their frontline clinical practice, raise your hands if you think doctors are the best. There's no one on your side here, Carlos, there. Raise your hand if you think nurses are the best. Okay, we have some guarded votes. Raise your hands if you think therapists are the best. I think therapists just possibly have it, and some of you are being kind. I think therapists may win. There's a lovely little study on doctors' psychic powers. That without actually administering the 10 questions of the AMTS, they're pretty convinced they can tell you what score the patient should get. And to be fair, at extremes, we're all pretty accurate. You know, if I guessed anyone in the room here was 9 or 10 out of 10, it's a pretty safe bet. If someone can't answer any of your history, maybe thinking they're a 0 is. But overall, 2/3 wrong. And 1/3 very wrong, either missing a significant cognitive impairment or diagnosing someone with them when they weren't.
Francis, maybe we should have family there as well. Family will tell you pretty quickly that that's not right for that person.
Well, if I put family as the list there, I think we would all have voted for them, wouldn't they, by far? Yeah. Nurses have to plead guilty too. I never got around to publishing this, but I did a survey in my hospital because we wanted to prove the need for an elderly psychiatry team. So we had to prove how many patients we have with cognitive impairment to prove the business case. So we did a survey, but before we did apply questionnaires to the patients, we asked the nurses on the ward, who have you got who's forgetful or confused? For every 3 patients with a significant cognitive impairment on screening that day, only 1 was flagged by the nurses as forgetful or confused. And we think this is something to do with if you are pleasantly confused, horrible word, people let it go. Now, my classic that day was a lady I found who had a score of 0 out of 10, you know, so she did not know where or when in the world she was, bless. But she smiled. Whatever the other patients did, she copied. And she had stayed under the radar for a week and they had not realised she was confused, which clearly makes the risk of someone's forgetfulness and risk of falls much harder to manage. What we also found in FallSafe, where we did give nurses the confidence to do more formal assessments of memory, was therapists were very, very good at it. And therapists would often lock up their record of a more sophisticated cognitive screening they had done with the patient and keep it in the therapy office. And it was not necessarily known to the other staff. They may not have needed the detail, but they could have needed the headlines. And last week, Diane too, we were listening to Jacqueline Close speak in Australia, who was saying what really tells you a lot on memory tests is not the score, but the words and the style that people respond in, and I think there's a great deal of truth in that. So it really is somewhere for your listening skills rather than your counting skills. My favourite example from when I picked up something from the words was in abbreviated mental test score. There's a question about when did the First World War start and finish, which is a bit of a dubious question, but people don't seem to remember when the Second World War started and finished. They seem to remember the First World War best. And this chap said, oh, 1914. And I said, yeah, and when did it finish? And he said, after 6 million people died. He actually had a very low score, but he had a depression, not a dementia. And if you listen to the tone of what he was responding, you know, there were definite hints there. Delirium. We found a third of patients who fell in hospital had a delirium, but most of them had not been assessed for delirium. Assessing for delirium often seems quite difficult. We have the CAM, Confusion Assessment Method, which is doable, but is quite complicated to teach. We know the kind of patients who are vulnerable to falling are very vulnerable to delirium. Any of us, even in good health with normal brain capacity, if we had a very severe insult like meningitis, we would get delirious. But once you're frail and have multi-pathology, it takes a very tiny trigger to turn you into delirium. One sedative tablet could be enough to do that. And a lot of what I'm going to use on the slides on delirium comes from Jonathan Tremel, who's a geriatrician in Birmingham in England, who loves falls and loves delirium and talks very well about them. Loves preventing falls and preventing delirium. We did try and teach our FallSafe leads to recognise the difference between delirium and dementia, and they're good educational materials that you can download. But if you're only worried about one thing, you would need to worry about the loss of attention. So the little tasks like counting backwards from 20, or counting the months backwards, or counting the days of the week backwards, it's very significant if people at some point lose track and say, well, where was I? That should make you strongly suspicious of a delirium, that inability to concentrate on a task even for half a minute or so. So, key thinking is, okay, are they confused or not, having assessed that properly? But what's really important to spot delirium is the confusion new or different or fluctuating? And you have to find someone who knows the patient for that, coming back to Sandy's point. If you've got continuity of staffing, it's easier to do. You will notice the patient is not the patient they were the last shift you were working. Sometimes people notice because they've been on days off, and there's more of a contrast than people who've been around every day and haven't quite noticed a gradual deterioration. And particularly this sense that just because they're not agitated doesn't mean it isn't delirium, and actually apathetic delirium, where people are very quiet, subdued, is a greater killer than ordinary delirium, because you very quickly also become dehydrated, malnourished, and it probably is a sign you're even sicker than in the agitated stage of a delirium. You know, and everybody knows the flock picking type behaviour. You don't always see it, but if you see it, it's highly unlikely there's an explanation other than delirium. Now, delirium treatment is pretty much the same as falls prevention, multidisciplinary assessment and intervention. And falls prevention interventions are pretty much delirium treatment. You know, both need a multifactorial, multidisciplinary approach. Priority for both is to identify and treat underlying health problems that have caused the delirium or the falls risk. Managing pain but minimising medication, attention to hydration and nutrition, minimising unintended restraints. You know, having a drip up, having a catheter up is going to add to agitation. Having orientation materials visible, reducing noise, disturbance, keeping lighting low and even. And the TDA way of remembering, tolerate. You know, don't try and stop them doing anything that isn't actively harmful to them or other patients. Anticipate. If you're going to have to take bloods, you know, life is going to be difficult and there will be problems. And don't agitate. And a lot of that is about giving staff the coping skills not to be agitated themselves and fuel that cycle. So, just one more thought, that actually the majority of our fallers in hospital are cognitively impaired or have delirium. But every hospital falls prevention policy I have ever seen starts with the theory that all our patients are cognitively intact and do what we ask them to. Then it adds some afterthoughts for those who are cognitively impaired. So the suggestion I would like to leave with you is that in your policies, care plans, guidance, start with those who have a cognitive impairment and add a little PS. By the way, those who are cognitively intact, you can also. Because that's actually the challenge we need. Orthostatic or postural hypertension was very significant in hospital fallers. Even if perhaps it's not a long-standing condition, if you're coming in hospital with a sepsis, if you're unwell but you're still being given your antihypertensives, you may well have a temporary orthostatic hypertension, even if not a long-term. We don't really know how many people in hospital have it overall because it's not often done properly. It's a skill with a specific technique. The compromise, instead of lying and standing, of sitting and standing, is pointless. And equipment was an issue. Which do you prefer, a good old-fashioned manual sphygmomanometer or a beautiful $5,000 Dynamap or whatever your favourite brand is here? Of those of you who take blood pressures regularly, hands up if you like the old-fashioned. Hands up if you like the fancy. Oh, there, I'm preaching to the converted here. But this was an incredible challenge in FallSafe, where this was one of the interventions we wanted them to introduce. They were very wedded to their Dynamaps, which is definitely their favourite UK brand. We had to buy aneroid sphygmometers and we had to buy stethoscopes. They might have had the odd one, but they certainly didn't have enough to mainstream it as a way of taking OBS. We had to buy teaching stethoscopes because we had a whole cohort who did not know how to take a manual blood pressure. We had a problem in that we have charts that are geared towards early warning scores and don't really have room for writing a lying and a standing blood pressure. So we had to find other documentation. We had one subacute hospital where actually nobody knew how to take a blood pressure with an aneroid sphygmomanometer Hertz. So we had to send in teaching staff to teach enough of them to teach each other. And we had a bit of a difficulty in that we also had to teach the doctors about what to do with the results in some of these settings. Not, of course, where we had geriatricians, but surgeons could be a little bit, and now what? So we had to have handouts prepared by the doctors on the team to teach them. So it looks like a simple thing, but it was a major challenge that they rose to. And they got rates of lying and standing blood pressure recorded from starting about 10% of patients and lifting it up to 60, 70% of patients at best. Continence problems and falls. You know, again, the majority of fallers in hospital have some degree of continence problems, urgency. And this isn't really about incontinence, it's about people trying to maintain continence. If you were totally incontinent, perhaps there would not be a falls risk. Just a little bit of thinking. How long does the average patient spend in the toilet each day, adding up all visits? Just give you a few seconds to confer. Okay, what are my bids? Shall I start the bidding at 15 minutes? More than 15 minutes? Okay, 25 minutes? More than 25? 30 minutes? Yeah, 45 minutes-ish? Any hour? Right, yeah, so it looks like we're mainly somewhere between half an hour and an hour, and we know constipation is different, and patients like poor John that you heard from in the video who was left and forgotten in the toilet would obviously add to the score. Now, 15 minutes is about 1% of 24 hours, roughly speaking. So if we're saying 30, 45 minutes an hour, we're talking about 2% to 4% of the patient's day. We have at least 15% of our falls occur in toilets, which, given you only spend 2 to 4% of your time there as a patient, it means it's a significant risk area.
This is hospital we're talking about.
This is hospital,
and when
yeah.
you go, it's just interesting, Mum's been in recently, and trying to get a walker into the toilet.
You know, you keep getting ahead to me here. We're going to do, I've got my black gallery of toilets, and I will come back and hear you tell me which one of those your mum's walker will fit in when we get there. I will, I'll call you back then. But first I'm going to do the who goes in with mum in a walker. Privacy and dignity or safety first. We'll try again to see if John's loud enough, just briefly this time, talking about what we ought to do. If you had one thing to tell nurses who are trying to make their patients feel safer from falls, you know, what advice would you give them from your experience?
I think what patients need is a sense of security. I think under situations like I was in, there's a conflict between the privacy of the patient in the toilet and the need for security. I felt that maybe the nurse should have waited outside until I was out again. But I'm also very aware that nurses are overstretched in many cases and they have to go somewhere else. But that feeling of security, in retrospect, would have been fine. At the time, I was very proud of myself that I was making strides. You know, I was getting to the toilet and I was able to carry on by myself, and that was a big advance. But I needed, I think, in retrospect, that feeling of security outside.
Francis, I might like to give my story. I had a thyroidectomy urgently after I'd been only back in New Zealand a year at the end of 2010, and it knocked out my parathyroids. So I had no calcium production for a while and had to go for a week in intensive care. Now, you imagine the director of nursing in their own hospital being quite unwell, and I was really unwell. And so when it came to have my shower in there, I wasn't going to have a staff member helping me shower. So off I go, and I'm hypertensive as well. It's interesting because my blood pressure was low, but even with my knowledge, I was swallowing my own I was swallowing the tablets they gave me, which was my hypertension. So I get up to go to the shower, and suddenly the shower starts to move around, and I'm thinking, right, what I'm going to do. So the first thing was I'm going to get a towel around me because I can't have them coming in. But then I thought I'm going to call somebody and I'll sit on the toilet and wait for them to come. And so the bell was a cord and had the push on there. And when I was tugging the cord, because you forget, you know, like I didn't realise that you had to push because I was really starting to swim and I was out cold by the time. I did actually manage to get it pushed. And then I don't remember until I was lifted back in my bed, which was terribly embarrassing because it took quite a few of them to lift me back into bed with nothing on. I wasn't real impressed, but it's just my story because, you know, but I was my own worst enemy because I wouldn't have wanted anybody in there. But you also need the nurse to think, here she is, she's in parathyroid crisis, she's hypotensive, no matter what she says. I should have waited outside the door.
And that is the happy compromise, isn't it? And it's easy when you've got someone like Sandy or John, you can ask, or in Sandy's case, persuade NAG to let you stay. We will have patients who are confused. I don't actually think that's a terrible problem, in that I had an interesting upbringing. I had rival grandmothers. One was Salvation Army, no smoking, no drinking, Citadel on Sundays. Bonnet in the pub trying to tempt people off the demon drink with copies of the war cry. And I had an Irish Catholic grandmother who had a fairly relaxed approach to life. And especially, I think the aspect of the Catholic religion she liked was the ability to always confess afterwards. They brought up a generation of militant atheists who are very good at singing hymns, but they were very different ladies, you know, and I don't think I ever saw my Grandma Joyce's kneecap in her life, let alone any more personal part of her body. My Grandma Healy never let a toilet door stop a good conversation, you know, as she would leave it open so that she didn't miss anything that was going on. So generally speaking, I think we agonise a bit too much about what we should do in toilets. You know, keep it simple. If your patients can express what they want, you know, you've got a choice of going right away, staying outside or being with them. Simple. Ask them. If they can't express preferences, I think our attitudes to privacy are pretty deeply ingrained, and as long as there's someone who knows us, they know how we feel about those things, and that's what we can respect in a care plan. Now, I'm not going to intrude on my expert physiotherapy colleagues by talking about balance, strength, posture. I'm just going to ask, do we really encourage mobility in hospitals? There's a couple of really scary studies, one from the USA, one from the UK, that patients spend almost no time at all on their feet. 25 minutes when you weren't sitting or lying means 23 hours, 35 minutes sitting or lying in that UK study, most times when they walked less than 20 steps. So the vicious circle of losing confidence, muscle strength, even bone strength is significant. And the researchers are very clear this wasn't about people too frail or weak to mobilise more than that. They simply had no opportunity to mobilise. And people often comment how many hospital falls are associated with toileting, not just that 15% I showed you, but mostly if they fell while walking, they were walking to the toilet. If they fell from beds, it was because they were getting out of bed to go to the toilet. If they fell from a chair, it was because they were getting out the chair to go to the toilet. And, you know, who knows, circumstances unclear, they were probably going to the toilet. So it's not actually surprising that most falls in hospitals are connected to going to the toilet, because people never bloody move unless they're going to the toilet. And we don't always make that better with technology. I'm not going to go into all the evidence base for alarms and otherwise, but this is a genuine quote I overheard at a falls conference, you know, and that was partly because the other patient said to this patient, "Sit down, Mr. Smith." You know, the other patients soon learn what you have to do to stop that annoying noise. We had to put out guidance on the ultra-low beds because though they're a boon in many cases for delirious patients, they were being used for people who had fallen while wandering, with the knowledge that that would leave them stranded and not able to get up from the floor without nursing help, which might be unethical but is also very unsafe, because if you struggle to your feet from a low position, you're pretty well guaranteed to fall, and then you have a lovely crash mat to trip over. And intentional rounding. Now, you know, the idea of always making sure that our patients have everything they need is a brilliant idea. But like all brilliant ideas, some people take it a little too seriously. And we did have it taken very seriously. This chart you can barely see was 20 items that were required to be asked and ticked every hour in one hospital who introduced this. And it was introduced in some places very much as a top-down, thou must initiative. Paul Snelling writes very interestingly about it if you want to look up that article. You know, and they genuinely thought they were doing a good thing by, you know, no one ever pottered round the bed to fetch a drink or a handkerchief. It was always brought to them in their armchair. So, life has really changed for our surgical patients. I suspect yours too. Literally to the point where some are being mobilised for the first time in recovery in theatres, but where it would be very normal that you have 7-day services to mobilise people after orthopaedic surgery, emergency and elective. Why don't we do that for medical patients? You know, why don't we have that mindset that it's a key part of their treatment and recovery? I know it's probably because we never have enough staff and enough time, but I'm not sure we have that mindset. And maybe if we had the mindset, we'd find a little bit more staff time.
It's interesting, orthopaedics background, and I mobilise people. People say, "Oh, this is aged care. You don't have to try it. Yeah, but these people can sit here, or not at yours place, girl, but I've had it in other places because I work all over the place." You know, I sort of get pushed because or ousted because I'm trying to mobilise people and keep them mobile. We don't. And same with medical, because they say, "Oh, you're coming from a different background. You know, you're a different sort of nurse." And it's like we're all people. We need to keep our feet underneath it.
Yeah, we've all got the same bones and muscles, haven't we?
Muscles working.
Yeah.
But it's interesting. You do sort of get a little bit of a, you know, like, don't do that here. This is how we do it here. You're sort of out of vogue. We don't really want you here because you sort of make us do something we don't want.
Well, maybe that bit of doing something you don't want, we do need more of. We have in our guidance a rather vague, but promptly, you know, it's slightly vague, but it doesn't imply next week, does it? And we do have issues. We did an audit as to how many hospitals, if someone, as ambulances tend to do, left someone's walking frame at home and they were admitted on a Friday, was there any way in your hospital a new walking frame could be obtained before Monday? 1/3 could confidently say they'd do that. Another third could probably do it on a couple of wards like orthopaedic trauma, and 1/3 of hospitals could not do that at all. You would wobble and struggle at least until Monday. You know, and we have a multidisciplinary team in the week. At the weekend it goes down to nurses, often less senior nurses as well. We may have some therapy input. We tend to have it only for chest physio and certain surgical units. So, you know, it's incredibly hard to change working patterns, but we did manage for all of our falls safe wards really by not management but the local nurse, the local physio having a sensible conversation, worked out a way that there was more mobilising at the weekends when physio wasn't there. And as our brilliant lead physiotherapist said, you know, I haven't trained for 3 years to press 2 buttons on a walking frame to make it the right height. You know, if I can teach a therapy assistant to do that, I can teach any nurse or nursing assistant to do that safely enough to last to Monday if they're going to be walking anyway. It's one to think on. I think I'm only going to be about 5 minutes late for coffee, if people are happy just to do this bit. We will have some patients, we do all that, and they remain a nightmare though, don't they? Now, this little clip, which again I hope you'll hear just enough at the back, is what is allegedly a BBC comedy, a somewhat black comedy. I actually think it's the best nurse training manual I've ever come across. In a backwards way, as you will see. It tells you mainly how not to do nursing.
Hiya.
I'm the special.
The agency?
Yes.
Oh, it's for Joyce. Kim, do you mind just leaving the tea for a minute and show... What's your name?
Anne.
Could you show Anne?
Sure.
Yeah.
Okay.
Show her over to Joyce.
This
please.
way, Anne,
Thank you.
okay? Okay, she's just down here around the corner. Hello, Joyce. She's had a stroke and we're a bit worried that she might fall if she gets up, so if you just keep an eye on her all the time, okay? And give us a shout if there's anything you need.
Okay.
Have a little bit of this. I think I have some.
Louise, you had the chicken option, didn't you? There you go. Tuck in. Oh, sorry, I can't relieve you until after lunches.
Lunches?
Yeah, sorry. I've only got 2 nurses on and 1 special. If you could help me out, I would be very grateful. I think I need to have it now, really. If they can come up, that would be... No, what's going on? Our deep clean's been brought forward.
Sorry, I know it's a pain, but now we have to pull them back.
Okay.
Sorry, Joyce.
All right.
Oh, Joyce, nearly.
Television man is crazy, Sam with juvenile delinquent Rex. Oh man, I need TV when I got T-Rex.
Oh, Joyce, you all right? Kim, give us a hand. You didn't fall, did you?
Where's the special gone?
I don't know. Did she just skip off? Probably the end of her shift.
Like all humour, you see a little bit of truth in it, sadly, and I think that can be how one-to-one nursing sometimes works. Someone temporary, someone junior, someone left without real interaction with the patient. There's some really nice examples, one of which has coined the phrase, make specialing special. In a large teaching hospital where they added up, there was someone being specialed pretty well all the time, that they've done special training with recognised skills and status. You get a slightly higher grade of healthcare assistant for having learnt the skills of specialing a patient. They teach them more about how they cope than how to cope with the patient, because if the staff member avoids getting stressed, it all seems to work much better. Strict rotation and rest periods, and they have their volunteer organisation make up packs with adult puzzles, reminiscence materials, sweets, snacks. So there is something to try and engage the patient with. And it's not just used for high falls risk, it's used for people who might be wandering or, you know, might have other issues that need one-to-one safety as opposed to one-to-one clinical observation. I am, however, much more of a fan of permanent cohort observation, in that if you're going to spend a vast amount of money on staff, you have an ethical duty to try and do good to the maximum number of people. And even if you're one-to-one, you don't necessarily catch the patient you're watching, and if you do, it's probably not very good for your back. The difficulty with cohort nursing is to get people really to go in the zone of interacting, observing, but not disappearing off to fetch things, do things, wash people. So staffing-wise, it works far better that you just plan for it, deliver it, and move your most 4 vulnerable patients to that bay, so that at least you have a permanent sort of supervision cohort. And environments, we promise we will come back to the toilets after you've had your coffee break, but that will join up quite nicely with bread rails, so I think we can do the two things later. I've got a section on safer care environments, but I'm actually embarrassed to present it here in Christchurch, because you are seriously world famous for what you're doing in terms of design and thinking out the box as you rebuild the city. So be kind and be forgiving of the slides I'm about to show, which are ones I show in other settings without your knowledge and expertise. Our guidance suggests we need to take a careful look at flooring, lighting, furniture and fittings such as handholds. And just a small reminder that it's not just a safe environment for people with poor mobility. We have very high levels of poor vision in fallers, and when this says impaired vision, it means less than 620, which is enough to be technically registered blind, and that was over a third of people who fall in hospital. And we're not good at any kind of vision assessment in an acute hospital setting. We're not even always good at making sure they've got the glasses in reach on bedside audit. There haven't been any recent studies in the UK or elsewhere that I know, but there was one done about 15 years back now that found when there are eyesight problems in hospital patients, they were usually treatable. It wasn't that they had eyesight problems that nothing more could be done with, often very out-of-date prescriptions or cataracts. Though there is a wealth of literature on this, some of you may be aware of, that changing people's glasses is not always a force for the good if they become used to the old prescription. And if patients have cataract surgery, it seems really important that they have the second eye done very soon after the first eye, because actually having bad vision in both eyes seems safer than having good and bad, with all the problems that gives you with binocular vision. We try a couple of techniques to get a bit more vision assessment in acute. We have what's called nurse's pocket test, so key, pen, scissors. If you stand at the end of the bed and your patient can't tell the difference between those three when you hold it up, they probably can't see their own feet, which is enough to know they're a significant falls risk. It's a blindness test, not a vision test. Holding things up at the end of the bed, my nurse's back. And the last one, this works. I think you have Specsavers in New Zealand, but I don't know if you had the same adverts, the old adverts where people looked very untrendy and were shunned by their friends because their glasses looked old-fashioned. Well, we had those Specsavers adverts. And actually, if you look at older people in hospital, if they have a very ancient, old-fashioned frame to their glasses, odds are the lenses are almost as old. So it's a good indicator they may need to see an optician. The toilets I promised I would come to. I have a little black gallery here. What a good place to put the emergency call board. Very useful. You'd have to unwind it before you could tug it, I think. And you certainly wouldn't reach it if you were on the floor. Ingeniously placed toilet roll. This is one where your mum and her Zimmer frame would definitely not fit in. And just to add to your joys, a shelf that is useless for anything except gouging a lump out of your forehead as you stumble. And if toilets weren't hard enough, we then require you to stand on one foot to open the pedal bin to throw away your paper towels after you've washed your hand. But it isn't only old toilets. Now, this one would have been lovely for your mum in a Zimmer frame, and it has some good things about it. They've realised some gentlemen like to pee standing up, so it's a good idea to have a higher handhold for them. They've got excellent colour contrast so that you can actually see the toilet standing out from the wall. I still have no idea where they've put the toilet roll or the emergency buzzer, but they're trying. We also have issues, cognitive impairment, some other neurological disease, how we perceive colour and shapes. So patterns, flooring can be very confusing and look like steps that aren't there. And if you've ever stepped on a step that isn't there, you know how much that leads you to fall. If you have patients with dementia, look how they react to blue-green flooring, that some of them seem to perceive it as water and then are cautious or anxious about stepping on it. And lighting. Okay, a bit obvious. The thought I want to leave with you is the problem of abrupt light gradients. So in a hospital ward at night, you follow a night light, you go to a toilet where a bright fluorescent light comes on, and you then take your older eyes out of that brightly fluorescently lit toilet into a dimly lit room where those of us who are already over the age of 50 know we will see nothing, because the older you get, the longer your eyes take to adjust to changes from bright to dim lighting. So actually some even consistent lighting may be safer in hospitals at night. There are some good resources for making hospitals just generally more dementia friendly. This isn't particularly falls prevention friendly, that you can find if you probably just Google King's Fund Dementia. I doubt anything that you're not already aware of, but some nice thoughts and resources if you're not. The suggestion I'd make is you will have access to brilliant occupational therapists. Have we got OTs in the room? You know, who, when they look at a patient's home, can tell you exactly what's dangerous about it and what needs fixing. You know, use them for your hospital environment too, systematically. And if you can't rebuild, at least you can have minor works, you know, even changes of colour of paint or shelves removed can help. Because you like getting on, I just want to give you one more critical environmental facility many hospitals lack.
Where can I have a fag?
You can't have a fag in the hospital.
Have you got no smoking room?
No smoking. There's nowhere in this hospital that you can smoke.
Not at all?
No, there's nowhere in the hospital you can smoke.
But where are we supposed to smoke?
There is no smoking room anymore.
I could go out, shall I?
No, I'm sorry. You might have concussion. And all the doctors here today...
I don't give a sod about the doctors.
Yeah,
I need a fag. Listen, I'm an addict, right? You know, if I don't have a fag for a certain length of time, my hands go all itchy, I get headache, I have to have a fag.
Some of that could be just in your mind. It's perfectly possible to get through. Yeah, I have smoked. I used to smoke for 13 years, thank you very much.
Oh, and you gave up, did you? I'm going to go out and have a fag. You can't keep me prisoner here.
Whatever.
What?
I'll take you for a fag.
Oh, that's very good of you. You've
Come on
gone
in.
up a bit in my estimation. You're a smoker, obviously, aren't you? Yeah, well, you know what it's like then. I mean, you know when you get all the shakes and everything and you can't sort of... Woo, oh.
I knew this had happened.
Oh.
Ivy.
Oh.
Ivy, you are not very well. Can you please go and lie down in your bed?
I've just had a bit of a funny turn, that's all.
Kim, I knew this had happened.
Dan,
Yeah.
can I still go out for a fag?
See on the UK news on the weekend when I was on night duty that there was a hospital in the UK that has decided it's absolutely ridiculous to try and stop people smoking. They are setting up special smoking sheds in their hospital grounds because making people walk onto the pavement was just ridiculous.
Yeah, I totally agree, and that's why I show that.
And these are the patients that you really think.
Yeah, yeah. You know, it's a difficult thing, isn't it? And a health message is well and good, but I certainly have had very sick people fall in a smoking shelter or outside, which, you know, isn't a good function of our duty of care either. So one to think about. We've done the wrong thing, but we are reverting in some cases, as you'd read. I'm just going to swap to something you can have a bit more of a discussion about to give you a little rest from listening to me. But we had some significant problems after patients had fallen in hospital where we were really adding insult to injury. And we had to issue advice in the form of a rapid response report in which we required certain systems to be in place. But part of the trigger for this was the gentleman you can see in the picture, and it's a photograph that's in the public media because his daughter had had a very difficult journey with the healthcare of a disabled son. So when things started going wrong with her father's care, she was taking photographs, she was writing notes, which made a very unusual record after he sadly died after a hospital fall. And this is him actually slightly after he had fell. Just about everything that could go wrong with his care did go wrong. He ultimately was found to have a spinal fracture and a subdural, but he was hoisted up from the floor. On the advice of a junior doctor who thought it would be easier to examine his spine while he was in the hoist. Neuroobs weren't taken very well, but more worryingly, when the neuroobs started to drop, nobody really knew what they had to do about that and didn't communicate effectively with the medical staff. The hospital had a general policy that if you were going for CT as an inpatient, patients who arrived in accident and emergency bumped you out the queue. So though his need for a CT was acute, he was bumped out of the order by everyone who arrived in a head injury in A&E, so took far longer than he should have, and was beyond saving by the time they diagnosed a serious subdural. Most of our inquests don't have a jury, but when they're very serious or very public concern, they have a jury inquest. And this had a very fair coroner and a very fair jury, but at some point in it, someone made the comment that it actually would have been better for this man if he'd fallen in the road outside the hospital, because the system was geared to detect and treat the injuries in a way it simply was not when you fell on a medical ward. And if we look at the serious injuries reported to our national system, about 14% of those frontline staff reports do describe some aftercare problem, either in retrieving them from the floor or in diagnosis or treatment delay or error.
Just to clarify, that figure around fractures is just in hospital.
Sorry, that's the hospital fractures, yeah. Yeah.
We think of the whole.
Yeah, no, yeah. Thanks for pointing it out, Sandy. Yeah, I'm just talking about falls in hospital. And this problem is really just an issue of falls in hospital, as in an A&E department is very geared at least to treat your injuries if you fall elsewhere. So we were getting it wrong in probably at least 200 people with a serious injury in a hospital fall each year. And this is the example of, this is verbatim from an incident report. I'll just give you a chance to read it. If anyone can't see from the back, wave at me and I'll read it out. It's a slightly extreme example, but it's from a subacute unit which wouldn't have had a doctor on site and would have relied on doctors visiting at a particular time of day and probably only physio senior nurse support in ordinary working hours. And it is very hard for doctors because if you think, we know from our injury rates in hospital, it's only about 1% that has any serious injury. So of all the times a junior doctor is asked to examine a patient who's fallen in hospital, most of the time they're going to be fine, some of the time there'll be a minor injury. 1 in 100 times there's an injury they've got to find, but they will be a little bit inured from looking at all those no harm, low harm falls to keep in the head that this time it could be serious. And we have an issue that most hospital falls are unwitnessed. I suspect the same is for you, because if someone's in sight, normally you can prevent it happening. And we have patients who are on much higher levels of warfarin than in the past. We have If they're not on warfarin, they're on Fragmin to prevent DVTs and PEs whilst they're in hospital care. So what can be a small, slow subdural bleed can become catastrophic in a relatively quick period of time. And this scenario where no one had found it until they were beyond any possible help is fairly normal. We also found most hospital wards rely on slings. Now, if you retrieve someone from the floor with a suspected hip fracture, just picture that sling, picture where the bone is broken, picture the pressure it would put on. And yeah, so actually making sure they have access to safety lifting equipment was important. And particularly, and this is what I'm passionate about, a fall really is a red flag that quite often something else is going wrong. You know, they're brewing a chest infection, they've had another cardiac event, they've had a cerebral event. And we know there's very high mortality in syncope fallers and high mortality in repeated fallers. So we need the doctors to be thinking, have they fallen because they're more ill, as well as are they injured from the fall? And yeah, again, this covers subacute and mental health units as well as acute hospitals, but we did not do well for medical review after a fall. And I suspect a lot of that is about nurses saying, he's had a fall, you know, you ought to come and see him, but he seems fine, you know, there's other patients you can worry about first. And we had some, we weren't clear if they were reviewed formally for injury at all. So I'm going to give you about 10 minutes this time, but in the minutes and hours after a fall, there's a great deal to do and remember. There's avoiding the mistakes we found some of our staff were making, but there's everything from informing the family to starting your secondary falls prevention plan, to managing the rest of the care when this has probably disrupted your routine. So what I'd like you to do, and possibly keep and use if you find it of any use, is to discuss with your colleagues. You know, if you were writing some kind of aid memoir, checklist, reminder for a new colleague on what they need to do after a fall, have a think about just how many things you might need them to remember, and see what you could get out of that in a 5 or 10 minute discussion. Some of you found this very easy, I understand, because some of you already have this checklist in use. Can you just put up your hands if you're a unit that has this kind of checklist all ready to work to? There. So there's some good practice that others can come and ask about in breaks later. Was there a lot to list and remember? If it was a junior member of staff, would they remember everything you've just remembered? So all I would hope is, we worry a lot about falls prevention rightly, but what happens after a fall is important too. And if your unit, your setting doesn't have something that makes it easy for staff to do the right thing, perhaps that's something that after today you may feel you wish to develop.
Can I just ask about, because we've had quite a lot of, well, I find it a dilemma about calling medical staff for a fall, because it used to be the rule of thumb that every fall had to be assessed from a medical point of view, and we've drifted away from that. I'm just wondering sort of what's happening in your neck of the woods around that.
It depends a lot. What we tend to have is quite a lot of advanced nurse practitioners who are the filter between the ward staff and medical staff who are thin on the ground, especially at night and weekends. We probably make that a bit safer by doing things like ECGs to decide whether or not. I think the honest answer is too, whether you say you've got a filter or not, you will have, because your doctors will have many patients who are ill that they need to prioritise. So I don't think you can have that simple policy and they must all be seen immediately after a fall. You have to help your doctors prioritise their time to who needs them most. But I think we've learnt to err a bit more on the side of caution, you know, and that these are, 2/3 of these are patients with dementia who may not be able to describe either their fall or how they are feeling very well. We do know there's still a level of unexpected death after falls where probably it wasn't the fall, but it was a sign something serious was going wrong with their medical condition. So I don't think we've got the perfect answer, but you know, I don't think it's only good to say everyone must be seen immediately, because that just isn't life in a busy hospital, is it? But err on the side of caution, we've learnt to our cost. We will have about 15 minutes to talk about bed rails, and I've got a few slides, but I'll ask Carl to chip into discussion, hopefully, as he knows far more about your local systems for that. There's a lot I've written about bed rails that if I just make you think today, you may want to go away and read and claim more CPD credits or whichever yours are called. But it's a funny thing how people talk and think about bed rails, and these seem to be the main three arguments I was very used to, that it was morally unacceptable, inherently dangerous, and they increase the risk of falls and injury. And there's some very strong language in the literature about bed rails. I can't think of anything that gets quite as polarised, except perhaps things like the use of Ritalin in children with AHD, or perhaps some of the immunisation debates. It's a very polarised, very strong language for their use. And we had an issue that we had about 20% of our falls were falls from bed. So we did have to think about bed rails in the UK. And the question is, are bed rails restraint? You know, if restraint is the intentional restriction of a person's voluntary movement or behaviour, if it's stopping them from doing something they appear to want to do, that's, to me, that is a much more useful definition, especially the last plain English one, to help us understand when bed rail use may or may not be appropriate, than anything that we get from the technical definitions, which says certain things are a restraint. You know, anything is a restraint if it stops you from doing what you want to do. But all this adjacent to the body and limits movement applies to plaster casts, bandages, IVs. You know, it may be helpful as a research definition, but I'm not sure it's helpful as a clinical one. And it's a complicated literature, and there is the famous Dr. Carl Hanger on this slide. But it does look like that some of the American studies that were very evangelical about bed rail reduction, that it was an evil that had to be eliminated, did statistically increase falls. C study is a classic one. It was a stroke rehab unit. They took away all bed rails overnight, and the only way you could get it back was by falling out of bed 3 times, which seems a little excessive. And if you were a newly admitted patient, you were not allowed bed rails for the first week, and then if you insisted, they might assess you after a week. But they felt they had to wean you off this evil equipment. The other studies there were much more reasonable. Capizuti's studies, they weren't trying to eliminate, though they did start with a cohort that were all the ones using bed rails and managed to reduce it. And a modest, sensible reduction in Carl's study, which had slightly unclear results, hence the question mark, depending which way you analysed it, perhaps no change. But it's something where we have very strong opinions. There should be Vegemite, I assume, if I'm this side of the world, or is Vegemite only Marmite? There you see, your UK heritage. Yeah, there's all things we do love or hate, but it's not really our opinion that should count with bed rails. They're not being applied to us. And though there's very sparse literature, we know patients do have an opinion. And there is a stroke club somewhere in the Midlands who is probably still telling their relatives about the day these two deaf women came and talked to them about bed rails, as though, you know, and they practically said to me, you know, get a life, love. You know, they were just a bit of metal that stopped you falling out of the bed, and they had a very chilled attitude, but they hated them being cut sides. And there's certainly some patients where they've called distress, some who like them, some who are neutral about them in other studies. And an amazing number of Ian patients who thought they were acceptable. Though I suspect that might be a little bit like telecare. We have a lovely study of telecare, which when you ask older people, do they think telecare is a good idea? 80 to 90% say yes. And when you say, and would you like telecare? 10 to 15% say yes. So the inherent dangers. There was a lot about you know, how they can cause direct harm. And indeed they do. This is the kind of studies that were totaled, particularly in the USA, of all the zones of entrapment. The real tragedy about all of those cases, well, it's not a random risk, but it's due to outdated equipment. We buy mattresses when the bed is still going to last far longer than the mattress, so it's an incompatible gap. And they're incorrectly assembled, wrong gaps, not fixed properly. This is the particular risk in that this gap you need to be either too narrow for a neck or so wide you can cheerfully push your head in and out, and that's the typical fatal zone of entrapment. And we use them inappropriately with agitated or distressed patients. And has anyone in the room had considerable problems getting a limb back out of a bed rail in which you can't quite work out how it ever got there, let alone how to get it out? And the dimensions are made fit for the average adult from about 5 foot to 6'2", and if you're very petite or very large, it will not be a safe bed rail for you. And this is a young man who died in hospital in the UK in 2006. He was a child-sized disabled adult, and they did not realise that actually the entrapment gaps on the bed made an adult bed unsafe for him, and he died of a postural asphyxiation. We still have unsafe equipment hanging about in our hospitals after years of directives and warnings, and we know care homes, aged care settings sometimes tend to be worse because they tend to have bits and pieces of equipment, a mattress, a bed rail, a bed that's been brought together from different manufacturers rather than a main bed. We know decision making. We try and encourage this balance between their mental state, their physical state, when bed rails are contraindicated, when they're recommended, which isn't always easy, but this risk matrix seems to work best as a guide to professional judgment. And we have problems both ways every time we audit. We've got some patients who really ought to have a bed rail. It would not restrict their mobility. They're perhaps hoist dependent, could topple out of bed. But we have other patients who really should not have them and do. So, though I've got some little written case studies, I wondered if, Carl, would you be able to paint a pen portrait of a patient? I did mean to catch you in advance, but because of your phone call, I didn't. Or if I paint a pen portrait, would you take the discussion on what might or might not be right for them?
Yep, I can certainly give you certainly we've got one patient in the water who's got, I won't say whether he's got bed rails or not, who's had a big stroke a couple of years ago. He's got a left hemiplegia, he's got an attention on the left, and he's come in with reduced mobility, but he's unable to stand unassisted at the moment. And then he was, certainly last weekend, he was found beside the bed. Did that help?
No, that's a perfect pen portrait, yeah. What decision process might you go through in a hospital for a patient like that? Would someone talk through what their protocol, what their guidance would? Because that would be much more helpful in the room than I think what we're using in the UK. Kind volunteer? Who works in hospitals? They see no one putting their hand up in case they're picked on. Exchange meaningful glances with each other till someone volunteers then. And talk us through what your hospital policy would ask you to do for the kind of patient Carl just described.
Frances, I think that might be a bit, the question you're
Is
asking
it? Yeah.
is it probably about, do you want to know the care that they would put in place for that person with those lists, with that description?
Just more about how would you make a decision about bed rails, and if so, how would you do it? Is there any guidance or anything you would work from? I mean, my UK nurses would work from something like this, but with an ounce of professional opinion in too. You may or may not have some formal local guidance, but if you talk me through your thinking or what you feel you are or aren't permitted to do in your hospital setting.
I know there's something new that's just coming out now, but it's based on a similar matrix.
Yeah.
So perhaps the less mobile the patient is and more dependent, they haven't got sitting balance, then we tend to put a rail.
Yeah.
To those that are starting to mobilise, then we would remove the rail.
Yeah.
And perhaps utilise more supervision at that point when the risk is slightly higher.
The other thing, Frances, is to the certification people that come and do audits,
yeah,
tend to have a very black and white view of bed rails. So they've gone from the end that they're not appropriate, they are restrained. And so a DHB can be knocked down if need to get a recommendation around their restraint management, and most fail it across the whole country, might I say, on certification around restraint, or have some recommendations.
We've done a lot of work in Southern around just exactly that, and moving towards enablers and the real focus on the use of enablers, but that is around the discussion you have with the patient and the family, looking at the physical ability of the patient, looking at the impulsiveness of the patient, the cognitive abilities and those sorts of things. So, and essentially if a patient can consent and it's part of a treatment plan, we will call it an enabler, and we get right away from the need to document fully, other than recognise that it is an enabler as opposed to a restraint. So we've done quite a bit of work.
It's helpful, really helpful.
Can I just challenge the concept of enabler? Because I don't think bed rails enable much at all. I think enabling, or using that terminology, fudges the decision making in terms of, is this a bed rail appropriate clinically for this person as opposed to not. And I know in our DHB we've used enablers versus restraints sort of terminology, but we're trying to go to a sort of decision making like that. But I think people fudge it to make it an enabler, therefore they don't need to use a restraint policy, therefore they don't need to tick so many boxes. Whereas it's devoid of clinical decision making. So I think what Frances is asking us now is, when would we use bed rails or when would we not, and what's the clinical decision making around it? Because I was rung about my man on Saturday morning, or I rang in and they said, well, should we or shouldn't we use bed rails? That was the real situation.
What was the cognitive ability of this man and his mental function and ability to make decisions around his own safety?
He's certainly, in France, is 60% of cognitively impaired. He's not making sound decisions, but he's not obtunded either, so he's in that confused lack some insight sort of category.
But then when you get the family involved as well, and actually as part of that care, and get the family in and say, well, look, you know, because of your father's status at this stage, we'd like to utilise this. This is our rationale, but it will be a weekly review. We'd like someone from your representative to be here, because in a rest home we're not allowed to use restraint in New Zealand. Legally, we can use enablers, and that's a 3-monthly review with daily sign-off for each shift. And it has to be discussed with the family or the resident. If they're not, if they don't have the ability to comprehend, then they don't get it done.
I think that is, you know, I know there's a difference, which I was very tentative about not having the discussion myself. I don't like the enabler word any more than Carl, but I love ethical decisions of restraint. I do not see that if someone is a hoist-dependent stroke patient with bed rails up, that the bed rail is a restraint. I don't think they're an enabler either, but they are not stopping the patient from doing anything they want to do. You know, and I don't think we serve our patients well when we say this bit of metal is a restraint, you know, because it actually takes us away from the ethical decision that we should never be using it for someone who wants to mobilise alone, and we should never be using it for someone who's at risk of climbing over the top. But to change that into the black and white rule of we should never be using it, or our inspectors are going to criticise us, or our home licence is going to be revoked. You know, we do have research that shows other countries gone down that path of saying everything out. They have actually harmed their patient, you know, and everyone wants the freedom to get out of bed, you know, but there's no advantage to rehabilitation to falling out of bed. You know, and it's that difference between what actually you're stopping them from doing. But it comes down to your definitions of restraint in your legislation, I think. You know, and this stopping them from doing something they want to do. And even then, you may sometimes need to do it. You know, we had restraint guidance in which I wrote case studies because we were worried, you know, literally people were letting a delirious patient walk out into the snow because they thought it was illegal or there'd be assault or whatever. If they stopped a patient doing that, it was restraint, you couldn't do it. And even writing national guidance, when I was writing case studies to sort of show it was an extreme, but sometimes you would need to do that in the patient's best interests, my colleagues kept trying to rewrite the case studies with a happy ending, you know, whereby you didn't need to use restraint because you were so good at your engagement skills, they weren't delirious anymore. So it's a really difficult issue, and I knew we couldn't do it justice in a workshop. But maybe one to have a think about and perhaps more a read about in times to come.
Because we do have concrete beliefs that come with us from long time practice, like, you know, you've got to have bed rails up when you move somebody in the bed, but you know, our corridors are on a Grand Prix track, and we're not heading around the corner at 100 miles an hour and spitting the patient out at the side. So there's, you know, and should we not have bed rails on a bed, but if we need them when we do the assessment, go get them and bolt them on.
And with the electric profiling beds, that's much less of an option, isn't it? You either buy them with or you won't have them at all, which probably changes practice too.
So, Carl, what was the outcome of your dilemma?
No, he's got a unilateral bed rail on his left-hand side because he's got no idea where his left-hand side of the bed is. So he's only got one bed rail, and he doesn't roll out that side anymore. And he's not attempting to get out of bed because he's a two-person or one to two-person assistant. If he is mobile, then that would be quite a different scenario. Just picking up on your point, Sandy, I'll be honest and say when I did our study in the mid-1990s, I came back to a hospital that probably had about 70% of bed rails on and used, and I was appalled from a rehab point of view. And so my views were coloured by that, and when I wrote that paper I was probably pretty anti-bed rails, and I still get it quoted at me now that we're not allowed bed rails in our hospital, which is not true. But in fact, I think the beauty of science is that my view has changed. The data has changed, the evidence has changed, and so I've changed with it. And that's what we should be doing as professionals, not be stuck on bed rails are good or bad, but changing with the evidence.
In the individual.
And I too remember those days, Carl, and they were tragic. But you know, there's something about you go from one extreme to another, and you have to find your balance, having visited both ends, don't you? So this may be something.
And climbing over them, people get very clever. The sad thing for us, and we've had 2 fractured hips in this last 9 months, and one was squeezing between the gap between the red rail and going over the top, and she died a week later after her surgery to fix a fractured hip. But it just amazes me. It's like, you know, they just get over. People don't expect to have that ability. You can get out and over. Very, very good. And she was confused, and she shouldn't have had them up in the first place.
Frances, we're using mattress surrounds that are relatively new, and it's a mattress cover that goes over with a foam wedge right the way around. There's a gap in the middle should they want to mobilise and get up. So for people that would just be disorientated and roll out of bed because they don't know where they are, they hit that
absolutely brilliant,
and they don't fall out. And we've been trialling this for a year, and they're going really well.
And that again is that individualisation. That sounds a brilliant idea. But then again, for a stroke patient, where rolling isn't your problem, but your whole sitting balance, that's when that might not be the answer. And the more we can have more options, and I haven't done low beds because that would possibly take a bit too long, but low beds, like bed rails, can be restrained, and you know, it's this right solution for the patient and what their risk is. Probably good to swap to our wider panel for questions at this point.
It would be a good time
and just before people go, I've got 3 good news slides to show you to finish on a happier note than some of the trauma. But we could make our little panel now, perhaps.
So people got comments, questions?
I wanted to know about, you mentioned the safe footwear, which I think we all agree. Many people don't come with their footwear to our facilities, but also safe footwear, people often stop, we believe, wearing safe footwear because of the condition of their feet and their nails and verrucas and all those types of things. How do you address that, and what impact do you think that has on?
We don't have good enough podiatry services. The one thing we've been able to change is we had nurses had the fear of cutting toenails put into them.
Scissors, the scissors test. I don't see many people carrying scissors.
And actually, I will
can't
say,
see them anymore, Wendy.
Yeah, you lose them, don't you? But most older people's toenails, scissors won't do the job anyway. So part of it is having kit there. We don't do well enough on podiatry. What we do well in some of our hospitals is having footwear we can supply. We have driven out the foam disposable slippers. We have some good but relatively cheap, made for hospitals, slippers with backs, but they tend to be toweling and a non-grip foot, that are proper slippers that only cost about £3 to buy in bulk, so they can be given out to patients who have nothing without it being a good deal. And that was partly inspired by a hospital was giving people hip protectors because they had no shoes. We do use the non-slip socks, but mainly for patients who would get out of bed. We're very careful they're the tread all round, because if you have the socks with just tread underneath, you go to bed with them, they spin round, you get out on a vinyl floor. And we do have TED stockings now, though they're slightly more expensive, that have rubber grip on the bottom. Because I don't have the evidence, but the preponderance of TED stockings plus talcum powder on a vinyl floor is a lethal combination.
Thank you.
Can I just add a comment to that, Wendy, in terms of non-slip socks? I'm happy to use non-slip socks when they haven't got their footwear, but as soon as they've got their footwear, they should be using their footwear.
Yeah. And nothing is a substitute for a good shoe they're used to walking in.
I have seen an outpatient walking in the red socks with their, you know, leaving them on as socks and wearing them, and you know, with sandals.
And I'm told they're good for preventing cramp, even if that wasn't the original intention. Some people like to wear them in because
I work in orthopaedics and have a wonderful job at the moment of scoring joints for surgery. It's not such a great deal to be on. I had a phone call the other week and actually listening to you prompts just, well, you know, the patient that's waiting for a joint replacement that's actually not bad enough to get onto the list, and they're ringing up every, you know, you get the 2 weekly letters from the GP, this patient's getting worse, this patient's getting worse, oh, now this patient's falling. But, you know, is the fall because of the joint, the arthritic joint? It may be, but it could be a number of other things in the 81-year-old patient. But where do you know, in I guess our environment that pushes to push them back out into the primary care setting, those issues can be dealt with, I guess, by the GPs, but where is the best place that we give them advice to? You know, we can send them back to the GP, but the GP says, oh, you need to get your knee done, and I'll just write to the hospital again. You know, listening to you talking about, you know, eyesight, you know, your polymedications, all of those things, what's the first thing, or, you know, how do we deal with these people to send them in the right direction?
I do think you have that opportunity, don't you, for elective surgery. You have a pre-admission assessment of some sort. What is extremely difficult for you is if you see there's problems but the GP is only worried about the knee.
These are people that are even before they get into pre-assessment. They're people that may have been seen by a consultant say, yes, you'll benefit, but actually you're not bad enough to make it onto our list yet. So we're not actually accepting you in, and you sort of think, oh, okay, you're having falls, but it could be something else other than the arthritic joint. But, you know,
the routes we have is where there are falls clinics, that you can do a direct referral normally, and that's because patients don't always go via their GPs. So if there's some kind of direct access specialist clinic that lets you bypass that. Possibly the other route is, I suspect you're doing a lot on having people fit for surgery in order to be able to send them home more quickly afterwards.
Yeah, absolutely.
And actually a really good pre-surgical assessment would pick up any major cardiac problems, might pick up toxic drugs. An easy thing is to ask them to make sure their glasses are up to date before they come in. I bet you already tell them to have good footwear for rehab. So some of it can get covered in really good pre-surgical planning, but you know, maybe it's one where the awareness looks like it's there in your team. You need a route to be able to flag these people.
Yeah, well, they're people that aren't really, you know, they're not bad enough to be getting in for surgery yet. Well, they are, but we can't get them in yet. But yet they're sitting out there and you're thinking, oh.
Are you Christchurch based?
No, Invercargill.
Invercargill. Because the routes I would be thinking of is, have you got a community falls program? So it'd be that
I know ACC run, but I don't. Yeah, I need to find out about.
So that would be one route, and then using our own situation here, then rather than may not be necessarily a falls clinic, but the geriatrician, and through their service would be the other route. Because somebody that's falling is a red flag really, and yes, it might be their hip, but it might be a multitude of other factors as well. So you want those other factors to be looked at as well as the hip.
Ken, did you have a comment?
It was just that actually. I run this business in Canterbury, so this would fit perfectly into a comprehensive community-based program that would involve a falls champion going to a person's home, addressing the issues that may make them a falls risk, not just the joint replacement, but whatever else, and reconnecting with the primary care team around those issues. But any form of pre-rehabilitation is going to be fantastic for any surgical procedure and post-op. So there's all those opportunities available. I don't necessarily see that you need a specific service, but the idea that you would alert the general practitioner to the view that strength and balance can be improved. There's no reason why you can't refer to private clinics in the community anyway. Ask if cost is an issue.
We've got your green prescription here in Canterbury as well, which is a really good central, and Tai Chi, which has worked out really well, which is run and you can get funded through ACC, I believe, which is really beneficial to get people to the optimum level prior to having any of that surgery.
If I allowed one last question, mine's probably for you, because there I was talking about older people, and you have such a vulnerable client group in brain injury recovery. And most of what I've said probably doesn't help at all, does it? So would you have some wisdom to share on the special issues?
There's a lot that transfers through. I really identify with everything you said, actually. It's great. And in our service, I think I've really pushed with the staff when they do witness an event, that they really look at what actually happened at the time, and that care plan reflects the strategies for that patient. I think that's really important as well. And then talking about it as a team, and that's the other key things, sort of the three key things that I like them to do: disease, solve and spread. And I think the spread side of it's about talking as a team, and making sure that it's in the notes and that others are aware of what actually happened and why, so that the strategies are relevant for that person.
And it's that level of relative anxiety, the family, for all of us, is very anxious, but it's so pressured, isn't it, when they've had a brain injury and they fall and strike the head again. The emotional worry everyone carries, staff and family, makes it a very challenging job.
And we do use a lot of specials, and our plans for the future on our wards are for single bed areas, so we're going to need to be diligent there and looking at how we use our lounge areas. And when you walk through our service, the patients aren't in bed, they're out and about doing what they need to do, so it's a whole team issue no matter where they are.
Frances, we're just, as Chris alluded to, building a new hospital, and I'd be interested to hear on your ideas on flooring. We've been doing some flooring trials, and Carl's smiling out of it.
Yeah, no, Ken gave me a lift from the airport this morning, and we started to...
I'd be interested to hear from you.
Yeah, well, we've had a recent trial called Hip Hop, which used one bay in several hospitals. Had very ambiguous results, I think. You know, there was a little bit, the researchers were keen to make the best out of it they could. There was also a situation, because it was just one area, you had beveled edges, so, you know, people had to walk on and off it. One of the hospitals did find it difficult for staff in that if they were pushing a bed, pushing a hoist, it's soft, you know, it inherently gives. I think it's something you may get, it's possibly not ready for a whole hospital yet, unless you have a better technology than we trialled a couple of years ago. But it is the great hope for the future, so whether a compromise is that perhaps it's an experiment on one of your wards from the outset, you know, and the floor is actually lowered, so that's a built-in experiment, you know, with a view that you may find in practice either it's great or you have to change it, is probably about the level the evidence is on. It feels a bit balanced.
Reflects, I think, what the discussions we've been having, so it's affirming in that sense.
It's a balance between a low impact flooring versus the staff issues of pushing beds, which, and that is the compromise at the moment without good evidence in favour either way.
But eventually we'll probably have motorised beds. You know, that will be a way of the future. Most of the things that people currently push around manually will have, you know, the technology will enable you to engage it. And
the new stroke beds have got that. We're trialling at Wanganui. It's like an aeroplane. When
that's right.
The patient we were teasing them without being the pilot.
Can I just ask though, in the event of Christchurch in the last few years, how do you then evacuate patients if you've got to get them out in a hurry and you can't move beds? If you've got a soft floor.
Well, we haven't gone that route. We're trialling 3 different floors, and each of them has that push resistance problem. So we don't feel there's sufficient evidence to lay all of there with the new flooring. So it's watch the space at the moment. But I think it's got potential as a fall or injury prevention from falls, because it's unlike hip protectors or something like that. It's in place all the time. It's where you need it all the time. You don't have to think about it. It's there, but you've got to have some way of overcoming that.
The one thing we haven't trialled, and I have suggested, but I keep getting told one that's far too expensive, is like a dance floor, the bounce floors that are in some gyms and dance floors. But we haven't been able to.
It's still very difficult,
floors, you know.
yeah, because even hip protectors, when people wear them, you know, I know some people tell you the studies say, well, they work when people wear them. That isn't actually true. The kind of people who wear them tend not to fall in the same circumstances. So it's got to be an area to move into. For those of you working in community, what worries me is my mother's generation had deep pile carpets for the fashion. You know, I will not have a carpet in my house till the day I die, so when I am an older person I will be falling on hardwood. And there is a considerable change in, at least in the UK, in how we've decorated and floored our homes that will have an impact when we're older. I mean, even furniture walking in these minimalist days will not be as easy as in my parents'
I'm just conscious of time, so perhaps, Frances, you could leave us on a happy note, but interesting your comments about carpet and flooring and not having carpet in my home.
I just wanted to finish with, I don't think we do nearly enough to celebrate success. You know, we worry about the one patient who falls. You all do a brilliant job every day. This was just simple verbal feedback from patients on the Fall Safe wards. We asked them how they felt about the care plans that their nurses had explained to them. And the bigger the word, the more patients used it. We celebrate heroes in other industries that care about safety, and we recognise their achievements. You know, there will be patients somewhere out there, older people somewhere out there, who are celebrating a birthday they would not have reached without your mobility, falls prevention, care interventions. And last thoughts is, if you've got some new ideas from today, I would suggest rein them in a bit. The best thing we did in Fall Safe was only get them to change one thing at a time, and after a month or two, when they got it bedded, they did another. And the other thing is, there's an awful lot we have to do for falls, but make hay slowly. You know, get the absolute must-dos sorted before you get on to the desirables and the nice. I've got resource links that when we post these slides you can find, and some easy reading ones. But though you can't prevent every fall, you know, every day, every time I get a chance to talk to people like yourselves, I learned something else we could do to prevent falls, and I think we just have to keep that optimism and that spirit of trying. So thank you so much for sharing your time with me today.